So hi, I'm Dr. Sen-Gupta. I'm one of the epileptologists here at UCI Health. And today I'll be talking about epilepsy and sleep, which is actually a very important topic that, we see a lot of sleep issues in patients with epilepsy, and it's something to be very aware of because it does go hand in hand with so many other aspects of epilepsy management. So, as I said, sleep-related issues are pretty frequent in epilepsy, and there's sort of this complex interplay between sleep-related issues, the treatment of epilepsy, and then the epilepsy itself. So in a sense, it's kind of like rock, paper, scissors. There's this complex interplay between all of these factors, and we can't kind of see one in exclusion from the other. They all kind of contribute to everything else. So my goals today are to discuss some common sleep-related complaints in epilepsy, to discuss the types of interrelationships between sleep and epilepsy, and to also provide information on sleep hygiene and evaluation and management of sleep issues. So there's several stages of sleep. Mainly there's two types of sleeps. There's non-REM sleep and REM sleep, which I'll get to in the next slide. So non-REM sleep, or non-rapid eye movement sleep, is as we're transitioning into sleep. REM sleep is when we are actually dreaming. So non-REM sleep is broken down into three stages. Stage 1, or N1 of sleep, is characterized by vertex waves or positive occipital sharp transients of sleep, or posts. During stage 2 sleep, we see things like K complexes and sleep spindles. Stage 3 sleep is characterized by slow wave sleep, where there's these broad, slow 1 to 3 hertz delta frequency waves that predominate in the recording. Now, epileptiform discharges, which are the brain's irritability in between seizures in someone with epilepsy, these are activated by these hypersynchronous states that happen in non-REM sleep. So basically, the brain's activity is becoming more synchronized during some of these stages of sleep, like N1 and N2, stage 1 and stage 2. And it's during these times that we might see these epileptiform discharges crop up. Normally, when our brains are awake, our brainwave activity is kind of desynchronized. And so the epileptiform discharges, which rely on brain synchronization, have perhaps less of a chance of cropping up. But when they're in this physiological state in stage 1 or stage 2 of sleep, that's when the hypersynchrony there makes it more likely for some of these manifestations to occur and crop up. During rapid eye movement sleep, it's when we dream, we have normally loss of body tone, so we don't act out our dreams. And this is more predominant in the latter third of the night. The EEG becomes relatively more active and desynchronized during this time. And so this stage might be relatively more protective against seizures, with the epileptiform discharges appearing kind of more localized, as opposed to kind of more diffuse in the earlier states of sleep, where there's more hypersynchrony. So this is just an example of our progression from wakefulness to sleep. So during wakefulness, we typically see our posture waking rhythm. During drowsiness, relaxed awareness, actually, we see these alpha waves that come on. During stage 1 of sleep, there's theta waves and vertex waves that can be seen. Sleep spindles and K complexes are seen in stage 2 of sleep. Slow wave sleep is now just called stage 3. There's no separate stage 4, but basically there's these higher amplitude slow delta waves, which range in the 1 to just under 4 hertz frequency band. And then finally, there's REM sleep, where we dream, which is actually very similar to how our brainwaves patterns look during wakefulness. The only exception is that our bodies are paralyzed, so we don't act out our dreams. So this is just a chart of multiple different types of disorders and what the clinical features are during them in relation to sleep. So with regards to epilepsy, for instance, patients can be variably aware of their seizures. They'll have stereotyped behaviors. There can often be multiple attacks per night, and it can happen at any time of the night, but often can be more frequent in the first third of the night when brainwave activity is kind of more synchronous, or even in the latter part, because as one is emerging from sleep can also be a vulnerable period for patients to experience their seizures. Not everything, not all uncharacteristic body movements and episodes that happen out of sleep, of course, are going to be seizures or epilepsy. There's these non-REM parasomnias, which are things like sleepwalking, sleep talking that may occur, and those are not epileptic in nature. Their brainwave pattern does not show any bad seizure discharges during those times. Then there's REM behavior disorder, which is where there's acting out of dreams. In this case, the loss of muscle tone gets, the muscle tone that should be lost during our dreaming states, the mechanism to kind of do that isn't functioning as well as it should. And so people can unfortunately end up acting out their dreams, thus injuring themselves and or their bed partners. There's also other things like periodic limb movements of sleep, restless leg syndrome. There's also non-epileptic events that can happen as a response to stress, although those typically don't happen necessarily during sleep, but rather the emergence into or out of the sleeping state. Now, there's multiple epilepsy syndromes that are closely associated with sleep. There's focal onset syndromes like benign relentic epilepsy, Paniatopoulos syndrome. Frontal lobe epilepsy is sort of notorious for happening really out of sleep with these often complex motor movements and vocalizations that can happen out of sleep. And there's also nocturnal frontal and temporal lobe epilepsies as well. Generalized epilepsy syndromes like juvenile myoclonic epilepsy, generalized tonic-clonic seizures on awakening. Oftentimes with the latter, as the name implies, it's the coming out of sleep and emerging into wakefulness that can be a critical transitional period that causes people to have these generalized seizures. And then there's other sleep syndromes, that epilepsy syndromes during sleep, where the epileptiform discharges or the seizures just become significantly worse during the sleep state itself. And these are things like Landau-Kleffner syndrome or continuous spike waves during slow wave sleep. So again, kind of a busy slide, but just to show you that there's different types of seizures that have different types of risks in various stages of wakefulness or in sleep or during various stages of sleep. Just for instance, the intraventricular epileptiform discharges, which if you think of seizures like full-out fires, these would be not the fires themselves, but rather the sparks that are there, the abnormal electrical sparks that are there, if you will, that predispose to a risk for seizures. So these will often manifest during wakefulness and sleep, but they can increase through the sleep stages because there's more and more brain synchrony as you get deeper in sleep. And then as soon as you get to REM sleep, which is where you dream, there's brain desynchronization of the brain activity. And at that point, some of these discharges can actually have more resolution. And then another part here is the patients with mesotemporal lobe epilepsy are more likely to have their seizures during wakefulness, and patients with epilepsy that happens outside the temporal lobes are more likely to have seizures during sleep. So there's some trends to kind of keep in mind, and this will vary per individual depending on the seizure syndrome that they have as far as what stage would be the most critical or vulnerable for them. Like some of my patients will say, every time I'm going to bed, that's when I'm having these seizures happening, or literally the second I wake up, when I wake up, I have about 2 minutes before I have a seizure. If it's going to happen, it's going to happen in that time. And then for others, it would be sort of during the deeper stages of sleep in the middle of the night, they'll experience events. So these are important to think about because they can kind of give us some insight about how we might want to provide medications to try to help during those critical periods. So for instance, if someone's having seizures right upon awakening or within a minute or two of awakening, then I might say, hey, maybe take these medications literally the second you wake up, and maybe we'll add a rescue medication as well so that you're protected during this vulnerable time. The shorter rescue medication that's sort of shorter acting and at the same time faster in onset, so you're protected for that period. And then your normal medications, your normal brain and your usual brain rhythms will take over, so you're relatively more protected until the next day. in approximately the same circumstances. So these actually do help a lot with management to try to figure out when should I give somebody tell somebody to take their medications, and what medications should they take at what times to maximize their seizure control based off of their potential seizure risk at a given point during the sleep-wake cycle. Okay, so there's more to it though. The seizure medications themselves, many of them can have effects on sleep, both positive and negative effects. And there's kind of a laundry list that's listed there, but it's important to know that these sleep-related things can happen. For instance, lamotrigine, which is great as far as mood stabilization and giving people kind of an activating effect. The activating effect from that can also keep people awake at night and unable to fall asleep. So for certain patients of mine, we've actually just had to do extended release formulation and maybe give it in the morning so that there's relatively less of that effect when they go to bed at night, and they can fall asleep a little bit easier. Or we kind of have patients take melatonin in addition to what they're taking to try to facilitate the sleep cycle. And I'll get into some more of that stuff, but it's important to know that it's not just seizures occurring at certain parts during the wakefulness or during sleep. It's not just epileptiform discharges happening at certain points in wakefulness or sleep. It's also the fact that seizure medications themselves can play a role, certainly as far as either improving and or exacerbating certain aspects of sleep, which in turn can have effects on the seizure control. So again, it is a continuum and a cycle. It's not just a cause and effect. One cause may be the effect of something else that may be a cause for something else, and so forth. And so there's multiple aspects of the cycle that we really need to be attuned to when we're trying to perform optimal management. So to move on here, primary disorders of sleep and epilepsy are about 2 to 3 times more common in adults with epilepsy than in the general population. The most common sleep disorders in persons with epilepsy are insomnia, excessive daytime sleepiness, and obstructive sleep apnea. And I'm going to go into detail with each one of these here. Now, sleep complaints are associated with the lower quality of life. The effects of sleep deprivation on epilepsy are that seizures can be precipitated in patients, for instance, with epilepsies on awakening. Sleep deprivation can trigger seizures in many patients with epilepsy. This is why sometimes we try to do sleep-deprived EEGs so that we can record the brain wave activity at these kind of more vulnerable periods and try to get higher yield if the EEG isn't getting epileptiform abnormalities than if we just had a complete awake and drowsy EEG. Sleep deprivation can also induce these interictal epileptiform abnormalities. Again, these are these sparks that are in between seizures that themselves aren't seizures, but just suggest a risk towards seizures. So if they coalesce and happen in trains, they can kick off a seizure, but they're not the seizures in themselves. So these can also be activated by sleep deprivation. So insomnia is the most common sleep disorder in patients with epilepsy. Then obstructive sleep apnea is also pretty high up there. Excessive daytime sleepiness is another thing as well. And then there's restless legs and paroxysmal limb movement. So multiple things that can be considered. But starting off, let's target insomnia because that's kind of a big, major complaint in patients with epilepsy. So what is causing this and how can we do something about it? So again, as we said, 51% of patients with epilepsy endorse either moderate or severe insomnia. About 72% of patients with epilepsy rate themselves as being poor sleepers, and these correlate with more seizure medications that someone is on, and also are associated with the lower quality of life. So it's important that we target this so that quality of life improves. And it's important also to realize that the more seizure medications that are on board, there's this association with kind of a higher risk or higher odds, I guess, of having insomnia be a important factor that needs to be dealt with as well. So insomnia can occur for multiple reasons in patients with epilepsy. Excuse me, I'm kind of parched here. So Insomnia can occur for multiple reasons in patients with epilepsy. It can be due to poor sleep hygiene, secondary to effects of seizure medications. There can be nocturnal seizures that disrupt sleep. There can also be the presence of other sleep disorders that are contributing to the insomnia. So this is kind of a busy slide, but what it's getting at is that if there's poor sleep hygiene or issues with sleep schedules, then we have to try to treat those with either progressive muscle relaxation, good sleep hygiene, like not being up with blue LED lighting late at night, not doing exercise and activating things really late at night. If those are not concerns, then we wonder, are there some mood issues or restless leg syndrome? If not, then we can try to target medications and timing as far as medications as far as timing and dosages to see what's kind of going on. Then we can also look for any concerns for possible sleep apneas or other sleep disorders using a formal sleep study or polysomnogram. So it just goes to show that there's a multi-level screen that we can do. But I think the next slide that I'm going to show may be one of the most important. If you take away nothing else from this, just think about some of the considerations in this next slide, because these are things that patients with epilepsy can do to significantly improve their own sleep hygiene. And this in itself can be pretty huge as far as trying to solve a lot of insomnia related problems in themselves that does not require necessarily pharmacological intervention. Okay, so this is called restful rituals, and I put together this little collage from different things that I had found online. I agree with everything except what I've crossed out, and I'll get into why that is. But let's talk about some of what we can do for sleep hygiene. So sleep hygiene wise, create a quiet, cool, dark, comfortable bedroom environment. So you want to associate your bed with a nice, restful place. You don't want to associate with a place that is going to be super stressful and frazzled out where you can't fall asleep. Because once that association is there, it's not going to feel pleasant to be in bed. And once it doesn't feel pleasant to be in bed, it's going to be that much harder to fall asleep. So the first step is kind of priming ourselves to know that when we're going to bed, that it's going to be a nice place to kind of go to sleep. Then the other one is use the bedroom only for sleep and sex. Remove all electronics and other distractions. This again is important because electronic products in themselves, they have blue LED lighting. What that tells us, if we don't have necessarily the blue LED blocking glasses, that is telling our hypothalamus that, hey, this is like sunlight. We should be awake. We should be activated. And so if we're using our cell phones, using our tablets, especially without blue LED filters late at night, then that makes it even more likely that it's going to be that much harder to fall asleep, because we've now given our brains the signal that, hey, it's actually morning time, it's not nighttime. Other things are don't drink caffeine 6 hours before bed. So we want to make sure that caffeine use is done early enough that it doesn't interfere with being able to fall asleep. We don't want to drink alcohol right before bed because it will actually fragment our REM sleep, and we're going to get less restful sleep in addition to other fragmentation of our sleep in general. Ideally, you want to maintain a good wake up and bedtime routine. Schedule when you go to bed, schedule when you wake up. One nice thing about doing it that way is that at some point, if we can kind of adhere to those things, then even if we're having difficulty falling asleep because we're stressed out, we just can't relax enough. If we limit our sleep within reason to say, hey, I'm going to sleep, say these 7 hours I'm allotting for sleep, but no matter what, I wake up at the 7-hour mark, then bit by bit, as long as we don't nap for crazy amounts of time during the day, we maybe take like 1 or 2 20-minute naps in the day, our bodies are going to get tired enough that at some point when we go to sleep at the desired bedtime, we're going to fall asleep. So I tell my patients when there's insomnia or their circadian clock is completely inverted because people are playing video games or whatnot and maybe going to bed at 4 in the morning, waking up at noon and just can't fall asleep again at night. It's like, hey, you're gonna have to back this up bit at a time. There's no easy, fast answer. But that said, your body will fall asleep. I guarantee you are going to fall asleep as long as you set an appropriate time to go to bed and when you're going to wake up. You adhere to that. Take no more than brief naps during the day, maybe a couple of 20-minute naps during the day, no more than that. And then by the time you go to your desired bedtime, at some point, it might take a week, 2 weeks, few weeks, but at some point, your body will get tired enough that it will go to bed like clockwork when you are at that desired time. So like all things, it requires training, but that training and that investment is well worth it if it can avoid you having to take additional medications, if it can get you to sleep without feeling stressed about how you're going to go to sleep. That's like the worst thing, lying in bed feeling stressed. How am I going to go to sleep? That's not what we want to do. And so this is exactly why I disagree with this statement, once in bed, don't get up again. Most physicians would also disagree with that particular statement. The reason is, if you're lying in bed and you're finding that you're getting really stressed out and you're just not able to fall asleep, you're tossing and turning, you don't want to associate your bed with the place where you don't fall asleep. So at that point, it's better just to get up, take a little stroll, have a sip of water, use the restroom, read something soothing, listen to something soothing, go back and try again. And then again, just take patience, repeat the process day after day after day. And at some point, again, you will fall asleep as you would like to fall asleep. Okay. A few other things too. So other things that can help fall asleep. So, shower. If you take a shower, then, you're gonna, if you take a nice warm shower, you'll raise your core temperature, and then afterwards, when you get out, you feel drowsier. If you read something that's not, again, you don't want to read something that's crazy activating. You want to read something that's soothing. That will help. Prayer, meditation, relaxation, gentle stretching. Even this worry time bit is kind of cool. You just write down all your worries, so they're on paper, but you don't no longer have to worry about them. They're on paper. You'll see it tomorrow. Put it on the bedside dresser, go to bed. Soft music can also be helpful. So again, you want to make a good environment for going to bed, and you want to adhere to it. Napping wisely is also good, because you want to catch up on sleep, but you don't want to sleep too long or too late during the day, because then you're going to just offset your pattern and get back into the same cycle. Okay. And so this is the correct answer, which is get out of bed if you can't get to sleep, not what I've crossed out up there in that other diagram. Okay. So now insomnia is done. We're going to move on to excessive daytime sleepiness. So this is actually the second most common complaint in patients with epilepsy. Now, anxiety is found to correlate with excessive daytime sleepiness, and poorly controlled seizures is the strongest risk factor for impaired sleep quality. It's estimated that about 45% of patients who've got medically refractory seizures have had excessive daytime sleepiness. This is called the Epworth Sleepiness Scale. It's a self-rating of oneself of chances of never dozing to high chances of dozing in these various situational circumstances. The score can be tallied up, and at the end, we get to a level that we can look at this table to say, hey, am I excessively tired or not? And if there's scores between 16 and 24, almost certainly that should be evaluated by somebody to understand, is there maybe obstructive sleep apnea or something else undiagnosed is underlying this degree of daytime sleepiness. So this is kind of a good screening tool that we can use either at home or in the clinic, just to gauge more quantitatively our actual sleepiness, to be able to report to our medical practitioners. Okay. So over here, we've got kind of a flow chart for how to go about management and workup of excessive daytime sleepiness. So first things first, as always, is there poor sleep hygiene, altered sleep schedule, or sleep deprivation? If that's not the case, then has the bed partner maybe noticed that there's witnessed sleep apneas, or someone's just fidgeting or jerking around during sleep? That seems unusual. Or are there actually increased seizures that are happening during sleep? If yes to these things, then we want to optimize the medication dosages. If we're concerned for sleep apnea, we'll need a formal sleep study to actually diagnose that someone is stopping breathing during sleep and institute treatment appropriately. So those are some of the things that can be done. In addition, if those turn out to be negative, then there's conditions called hypersomnia, which can be primary conditions of excessive sleepiness. And so there's additional testing with the multiple sleep latency test that can be done to try to diagnose that and rule it out as a potential contributor. Now, this is obstructive sleep apnea. This is also a major complaint in patients with epilepsy. And generally speaking, it's the bed partner that will be the one that suffers a lot more than the patient, at least initially, because the bed partner will hear all the snoring, but the patient is still seemingly kind of asleep. But then during the daytime, the patient is the one who will be suffering And with the long-term health effects, the patient is the one who will be suffering a lot more, from all of this. So, what is obstructive sleep apnea? So generally, classically, the obstructive sleep apnea, the classic person who has this is a guy, a male who's bigger, who's stockier, who's got a thicker neck. And the reason for this is because when someone's lying back, an individual like that is lying back, then the soft tissues at the back of the throat can end up relaxing and closing off the airway. So intermittently, what's happening is that the person's trying to breathe, but the airway is kind of blocked. So snoring is kind of, so I do this kind of as a dramatic impersonation for my patients and their families. I say, okay, is the patient snoring? And then they'll say, oh yeah, they're snoring. And then I ask, okay, so is it snoring like this? Or are you hearing? And so if there's the second one, you heard that there's kind of a cessation of snoring and breathing and a snort. And that snorting and that cessation of breathing are what's concerning for the obstructive sleep apnea. Just snoring by itself is not necessarily meaning that there's obstruction to the extent to block off airways. But if we're hearing that actual stopping of breathing, that's when we become quite concerned. Are we dealing with potential obstructive sleep apnea? And this again is happening by blockage of the airway during sleep. It can be worsened by the loss of muscle tone during REM sleep. And so during that time, it results in arousals and sleep fragmentation, but the patient's often unaware of these during the time that they're sleeping. However, the next morning, it's a different story, because then the person wakes up, they might feel like they have morning headaches, can't focus, nodding off multiple times during the day, wondering, my goodness, I slept 8 hours at night. Why am I still falling asleep left and right here? Then there's not any aspect of life that is not ultimately impacted by obstructive sleep apnea and poor sleep. So these are things like mood, energy, concentration, libido, motivation. There can be increased strain on the heart from pulmonary hypertension that develops. And most importantly for someone with epilepsy, or most key for someone with epilepsy, is that seizure control also worsens in the setting of obstructive sleep apnea. And I'll talk a little bit about why that may be the case in a little bit. Now, the classic risk factors for obstructive sleep apnea that we talked about are males who are overweight with increased neck circumference, middle age, who've also got refractory high blood pressure. Obstructive sleep apnea in persons with epilepsy, about a third of patients with epilepsy have obstructive sleep apnea. It's estimated that actually 20 to 21% of the adult population at large in the US is dealing with obstructive sleep apnea. The vast majority, as you would expect, are probably undiagnosed. But clearly the prevalence in patients with epilepsy is significantly higher than in the general population. And this prevalence of obstructive sleep apnea, this increased prevalence in patients with epilepsy, is present regardless of whether or not seizures are controlled or uncontrolled, curiously enough. And if someone has a vagus nerve stimulator, the prevalence of obstructive sleep apnea can be even higher, up to 43% or so. Now, some thoughts are as well with the VNS is one might get decreased REM sleep, increased awakenings, and also increased wakefulness after the onset of sleep, and spend a greater amount of time in stage 1 sleep as opposed to the deeper stages of sleep. So there's other things that a vagus nerve stimulator can also do that may impact sleep. So how does obstructive sleep apnea actually provoke the seizures themselves? So frequent arousals during the REM. So what's happening when someone is, snoring and then having an apnea? So they oftentimes might have a little bit of moving around, maybe a little bit of repositioning, and then they go right back to sleep. The person themselves is not aware that they just did that, but the brain is like, hey, I was in a deeper stage of sleep and I just got aroused out of that, and I have to go back to a deeper stage of sleep. So from the brain standpoint, the sleep is not restful, even though the individual doesn't consciously necessarily recollect that happening. So these frequent arousals increase brain cell excitability, and then the decrease in oxygen that happens with these cessations of breathing or apneas can result in oxidative stress that then releases inflammatory mediators that can then make it more likely to provoke a seizure at some point. It's known in particular, notably, that treating obstructive sleep apnea in patients with epilepsy is associated with a fourfold higher odds of getting to seizure freedom. So again, this is not a seizure medication or device that we have to throw into the mix. This is simply management of obstructive sleep apnea that can help a substantial amount in regards to helping with seizure freedom, not to mention trying to mitigate against things like pulmonary hypertension, strain on the heart, memory issues during the day, issues that can result from excessive daytime sleepiness, like falling asleep in critical periods during the daytime, mood and concentration, better control of migraines. All that stuff can be improved by treating this one root problem. Okay. So what is the treatment for obstructive sleep apnea? Many of you have probably heard of something called CPAP. It stands for continuous positive airway pressure. So the way it works is it's a mask that goes over the face and the nose. There's also nasal CPAP as well that goes just over the nose. But the idea is that it prevents the person from taking a complete breath out. So just like a balloon, if you guys have ever blown up a balloon, you know that the first couple of puffs to actually blow up this rigid balloon, it's really challenging. But once you've got the balloon even a teeny bit inflated, it requires a lot less effort to expand it to the fullest. It's the same way with the alveoli or air sacs in our lungs. So what's happening is that we're not actually forcing air in per se. What we're doing is by keeping positive pressure against the airway, we're preventing the person from completely collapsing these alveoli as they breathe out. So they breathe out, the alveoli, like balloons that are slightly inflated, stay a little bit inflated enough such that when the next in-breath comes after the incomplete exhalation, that the balloon becomes easier to inflate and air is delivered easier, and inflation happens easier to be able to deliver air into the lungs. And that's really the approach for treatment here, device-wise. Other things, of course, that help, certainly weight loss. If someone is overweight and can lose weight, that in itself can help a lot with sleep apnea, and someone might even be able to get by without using a CPAP mask in these instances. So that these are definitely things that should be considered empowering aspects of epilepsy care, because they're not medication management related, they're not necessarily directly device related, just simple things like sleep hygiene, simple things like exercise and trying to maintain a healthy weight. These are facets that can substantially improve sleep quality, and this in turn can definitely have very positive impacts, not only on seizure control, but multiple facets of health and life in general. So in summary, sleep disorders are common in epilepsy. There's this bidirectional or multidirectional linkage of sleep disorders and epilepsy and epilepsy medications. Sleep hygiene, redosing of seizure medications. If someone really has very bad insomnia, we can use things like melatonin, which is a naturally derived substance that our hypothalamus, that our pineal gland manufactures anyway. And so we can basically end up, treating these sleep-related issues for insomnia quite well with that. So melatonin is something that can be gotten over the counter. It basically is something that can be taken before, maybe like an hour or so before the desired onset of sleep, half an hour to an hour before, that can be taken, and then try to kind of go to sleep. But ideally, with enough kind of training and redosing of medications, the need for things like additional substances would get minimized. But certainly melatonin is pretty harmless to give, and it can be gotten over the counter. And I use it pretty liberally to a lot of my patients who are having difficulties falling asleep. And so sleep complaints persist, though, despite doing some of these interventions. Then one can obtain a sleep study for formal evaluation going forward. Okay. So just wanted to drop the final slide there about connecting with us in our epilepsy group. We do commonly manage a lot of patients with sleep-related issues. We refer a lot of our patients for sleep evaluations, and we do a lot of the screening as far as trying to figure out if someone's having insomnia, undetected sleep apnea, and related disorders as well. And combined together with the standard seizure medications, these can be very powerful ways to try to help with epilepsy care. I don't consider these separate at all, because if we're just trying to go with meds alone, we're missing a large part of the picture. And so we as a team do continue to look at these constellation of things in order to treat patients with epilepsy so that we can offer the most effective treatments that are possible. So that's all I've got for now. Happy to take any questions, and I hope that was helpful. Okay, so I see. Can folks still hear me here? Yeah.
I can hear you.
Okay, cool. Yeah, so let's see. So what dosage of melatonin is reasonable? So I start pretty low. I could probably, honestly, I'd probably go higher to begin with. Usually I just do like a milligram or 2 at night for patients, but even going up to 5 or 10 is not unreasonable. 5 is actually a pretty reasonable dose. Sort of over 10 is where it might be a little bit on the higher side, but even 10 can be reasonable. But generally speaking, I think the average dose that I have for my patients is somewhere between 2 and 5 milligrams at night. Okay, next question, with regards to excessive daytime sleepiness, is that independent of drowsiness, side effects from seizure medications? The answer is it can be related to both. It can be from seizure medications themselves to some extent, but essentially if the sleep is fragmented during the night, or there's obstructive sleep apnea that's not treated, or if someone's having ongoing seizures during the night, then the next day they can feel pretty wiped out and get excessive daytime sleepiness. So it may be a combination of both, but certainly medications themselves can contribute if they're very sedating. However, we also have to think about other things that might be happening during the nighttime, like for instance, if someone has insomnia and is trying to re-regularize their sleep cycle and is very sleepy the next day, that's expected because they've been trying to go to bed at a certain time. Most likely they're not going to fall asleep till a while later, and then they're forcing themselves to get up to continue on about their day. If they've had obstructive sleep apnea, if they've had multiple seizures overnight, or other, like dealing with restless leg syndrome and are getting sleep fragmentation from that, those can be contributing to excessive daytime sleepiness. One thing to bear in mind is that obstructive sleep apnea can kind of masquerade in various ways. So a lot of these other sleep-related things, like people acting out their dreams, or sleepwalking or sleep talking, and this kind of thing, may actually all be related to an obstructive sleep apnea. So that needs to be the first assessment. And if these things still persist despite that, then that would be the time to do further evaluations. But obstructive sleep apnea is kind of the great masquerader of sleep. And like I said, it's quite possibly one of the most common conditions in the adult population in the US. 20% of patients, those 1 in 5 adult patients in the US is dealing with this, but certainly there's not that many people who are using a CPAP mask for their sleep. With regards to, sorry, what was the next question here? So if epilepsy gets treated under control, will sleep issues resolved? Again, it's bidirectional here. So it's hard. They can both be chickens and they can both be eggs, is the answer. So at that point, if someone's sleep-related issues are due to their epilepsy, then yes, improving epilepsy treatment can help sleep issues. For instance, say someone's having seizures during the night and those get controlled, and it's the nighttime seizures while someone is sleeping that is exacerbating sleep quality and therefore causing someone to be really sleepy in the daytime. Certainly treating the epilepsy there is going to help with the sleep fragmentation as well. And so in that case, it could resolve. But the other way too, there's also vice versa, which is someone having, for instance, obstructive sleep apnea and seizing overnight because of effects secondary to that. In that case, there would need to be a two-pronged approach of trying to treat both the seizures as well as, of course, the underlying sleep apnea to see which is kind of the bigger set of contributors, or maybe both are in that case. Is it concerned if a patient never recalls dreaming? Not necessarily, no. That the recall of dreaming or going into REM sleep, it can be highly, highly variable. So that by itself would not be something of concern, provided that someone is not feeling really excessively tired during the day, doesn't feel chronic fatigue, chronic headaches that are happening during the day. So in the absence of other symptoms, I wouldn't say that by itself is concerning. What I would say is more concerning is if family have noticed that we can hear our loved one kind of snoring through the walls here, and especially we're noticing that there's some pauses and gasps that are happening. That's the history that we really want to know, more so than necessarily dream recall per se. So would I recommend someone to to do a sleep study at a sleep center if they have a sleep issue? The answer is yes, with the caveat that those would require referral. And so as a first step, it's always good to at least go through the screening with one of the epilepsy specialists, such as what we do here. And we kind of go through some of these questions to understand, is there a reasonable suspicion in our minds that this is probably a sleep-related issue? And that way we then go and refer our patients to formal sleep evaluations, where a formal sleep history gets done. And then if there's still concern based off of that, then a sleep study can be done. But I think that the first step can be certainly just discussion with the neurologist or epilepsy practitioner, in order just to gauge, like, what's the probability that this might be an ongoing issue. And truth be told, we have a pretty low threshold for that. If someone gives us a few potentially concerning findings that might lead us down that route, we don't really hesitate to refer folks to sleep evaluation. So how many hours of sleep will be recommended for patients with epilepsy? So there's no set number. Generally, it just depends kind of with what a person feels adequately rested on. Generally speaking, 7 hours or a little bit more, 7 to 8 hours is not a bad range to try to target. Of course, some people would need more, some people would need less, but it's very individual dependent. There's other things to keep in mind. The reason I can't give a one-size-fits-all answer here is that there's some patients with epilepsy who are going to be very susceptible to even a small bit of sleep deprivation and would then go on to have seizures, right? Versus there's other patients who are able to tolerate that a lot better, not solely that they should, but the fact that they can. So within degrees of comfort, that's something to consider as far as how much sleep do I need in order to not have a breakthrough seizure just based on a sleep deprivation. And then secondarily, what is my seizure threshold like? How are my seizures controlled on the current medication regimen? When I have kind of gotten less sleep than I typically get, have I had any problems with seizures later that day or the next day? Or was I kind of okay throughout that? So these are things to consider as far as kind of targeting what would be an appropriate time for sleep. Duration of sleep for overnight. That said, during the day, we should probably limit ourselves to no more than two, maximum 3 20 to 30-minute naps. Kind of going significantly longer than that, you end up getting sleep inertia, where it's hard to come out. Like, you want to get that full REM cycle of 90 minutes, and then you basically destroyed your ability to fall asleep at night. So naps are great if they're done judiciously throughout the day, in very short kind of intervals. And you take the nap, do like the power nap, get up and move on and go about your day, so that you can still go to sleep as expected at night. That part is important. Okay, anything else? Okay, thank you everyone. Really appreciate your time, and hope this was helpful. Take care.